All right, welcome to another episode of the Hurwitz Lab. Today we have back Dr. Jeff Rimmer, the self-described ancient nephrologist, who I was lucky enough to share Grand Rounds presentations with back in this January, where we presented the evolution of CKD care. And he gave such an excellent review of the evolution of measuring versus estimating GFR and then leading into CKD classification that I felt like we should do it as a podcast. So here we are. Welcome back, Jeff.
Thank you.
Yep. Let me get this mic in front of you here.
All righty.
So they can hear you.
You've got to be able to see this. So.
Yeah, make sure you can see it.
Okay.
Perfect.
It's okay?
That's perfect.
All right.
Great.
Very good.
So where were we when we were just chatting? We were talking about why is it important? You know, what is it?
And I think I'm going to work my way up to that, if you
Okay,
don't mind.
let's do that.
I just think, I don't know who listens to these things, but I thought I would spend...
I told you it's really only one person. It's my mother. We mentioned that. And my father will listen, I'm sure, and a few friends. There's a few residents, but I think, you know, this is geared mostly towards people who are interested in nephrology, which I think the people who message me sometimes are mostly med students, residents, and a few fellows here or there. So I think those are the people we're talking to.
Alrighty.
Which is perfect.
Well, what I decided I want to do before I talked about the evolution of the estimated GFR is just talk a little bit about what the GFR is so that people will understand why we want to estimate it.
Perfect.
So
let's do that.
And I thought I would start out with the glomerular tuft.
Look at that. Brings a smile to my face.
And I just want to remind everyone that the glomerular tuft, the filtering unit of the glomerulus, is all part of a vascular arteriole. And so you have the capillary loops, which is where the filtration actually happens, and the endothelium in the capillary loops has most of the same properties as endothelium in blood vessels. And the mesangium is actually modified vascular smooth muscle that is moved off asymmetrically, where its contractile function can change the filtration surface area of the glomerular capillaries.
It's amazing.
But it's a blood vessel, and it responds to all of the things that blood vessels respond to, and it demonstrates the pathology that is going on in blood vessels everywhere in the body.
Mm-hmm.
So it is kind of a window to what's going on in the vascular system because it's making this stuff urine that's coming out, and we can look for changes in the urine, and those changes reflect often what's going on in blood vessels.
In other organs like the heart, the brain, the eyes.
Like everywhere.
Everywhere. Exactly.
So it gives us a clue as to what's going on. Now, the things that we're interested in is the filtration, and that is fluid moves from the blood across the capillary membrane into Bowman space, and then it goes down the tubule, which is pretty neat because of all the things that go on there.
I love the tubule.
You need to
but we're talking about filtration
you need to get
first.
Alan back to
yes.
talk about the tubule.
And we have. That's good.
And one of the things that the glomerular capillary does is it keeps big solute in the blood and just allows very small solute, things like electrolytes and creatinine and urea and those things out. So one of the signs that the glomerulus is damaged, and we're not going to talk about it today, is that large solute gets across the membrane, and that's where you begin to talk about the importance of albuminuria as an indicator of kidney disease and as an indicator of generalized vascular disease in a lot of circumstances. But what we're really going to talk about today is there's a lot of fluid that comes across the basement membrane. A normal, healthy person, somewhere between, 160, 140 liters a day of fluid. That goes across with the small solute, and if you're really filtering small solute well, the concentration in the blood is going to be the same as the concentration out in Bowman space, that you will have no barrier to filtration of solute. And that's where we're talking about filtration markers. That's never really true. Even with sodium, I think it's like 99.9%, that sodium gets concentrated a little bit in the blood. But for the most part, this solute gets across the basement membrane. And that's what filtration is. The fluid going out and the fluid carrying various kinds of solute. We always imagine all the toxins and everything going out, but
isotonically, however it was in the serum is how it's coming through on the other side for the most part, except for large particles. Right.
So that's what filtration is, and that's just a reminder that as filtration declines, that is a marker for kidney disease, but you frequently are talking about disease in blood vessels everywhere as you see the GFR decline. And so that becomes one of the important reasons about following what the glomerular filtration rate is, not only to see exactly what you're filtering, but does this indicate what's going on other places in your body, independent of its relationship to your kidney function?
Right. And there are changes in filtration that are just autoregulatory, that are in the normal range of managing this filtration, keeping it even throughout ranges of blood pressure and other things, or related to medications. It doesn't always reflect damage.
They're actually, I'm old, so I grew up with the Brenner hypothesis. And
this is what we want to tap into. We need the historical perspective. That's what's so important about having you here.
So Brenner really promulgated the idea that a lot of chronic kidney disease is related to high filtration pressures within the glomerular capillaries, and that there is some barotrauma to the capillaries, and that's in many forms of kidney disease, what relates to the progressive kidney disease. But his idea was that, in fact, our normal GFR of 160 liters a day, 120 milliliters a minute, is abnormally high, that it is a product of the Western diet we eat, where we're eating a lot of meat, and that meat is continuously stimulating a high GFR teleologically to be able to excrete the nitrogenous waste associated with the meat load. And so Brenner would say your GFR really ought to be 60. Now, all of this seems very tangential, but that gets me back to, in a human being, you can see the GFR vary between 60 and 140 in somebody who's got entirely normal kidneys, depending on what the stimulus is for filtration.
What the needs are.
Yeah.
Yep.
All right. How do I go forward
Cool.
here?
Arrow to the right. Let's see, your arrow.
Arrow.
That one.
That one.
Yeah.
Okay.
Perfect.
So we'll talk about exogenous markers in a minute, but what we really want to talk about are endogenous filtration markers. And that is solute that is organically generated in the body in one way or the other, but it functions as a filtration marker. It gets across the basement membrane freely, not bound to proteins, not so the blood concentration and the Bowman space concentration is pretty similar. And if you have that kind of filtration marker, although the two big ones are creatinine and cystatin C, with creatinine, you can do a urine collection and see what it is. With cystatin C, you can't do a urine collection because it's filtered, goes into the proximal tubules, reabsorbed, and
processed.
It's hydrolyzed and goes back.
Disappears, right?
Yes. And as actually,
which is so interesting.
Well,
that it measures clearance, but it doesn't actually leave the body. But it's filtered.
That's a whole nother topic about the importance of the clearance of low molecular weight protein. And that, in my mind, has always been a very important, neglected part of kidney function, the clearance of particularly peptide solute with molecular range of about 5,000 to about 15,000. Because when you look in that range, those are all of the signaling proteins, the proteohormones, the cytokines, and the metabolism of those low molecular weight proteins is really abnormal when you've got a reduced GFR. And I've always pondered, how much does that contribute to the pathology of having a reduced GFR? Hasn't been a big topic. But back to endogenous markers, they're freely filtered, and so they go up in the blood as the kidney function declines. And if it's a good filtration marker, elimination from the body is entirely dependent on kidney function. There shouldn't be any other mechanism of eliminating that solute. So whatever the rise is in one of those plasma filtration markers is going to be proportional to a reduction in your filtration rate.
Got it.
The difficulty with that, and again, the old doctor thing, is I actually come from the days where the most common measure of kidney function was the serum creatinine. And that people would look at the serum creatinine and make a judgment as to whether or not somebody had significantly reduced kidney function. And the normal serum creatinine back then was probably 0.8 to about 1.5, 1.6, that sort of range. And so if you were in that range, you had normal kidney function as far as we were concerned. And even if your creatinine was 2, gee, that's not very far from
not impressive.
1.6. So that doesn't, you don't really have significant kidney function. And unless you were a nephrologist, you probably didn't realize that there was an exponential relationship between the decline in the GFR and the apparent linear rise in the serum creatinine. So next figure is the serum creatinine graft versus the actual measured glomerular filtration rate.
I love this slide.
And these were really classic. These were inulin clearance GFRs. And what you can see is sort of what I was talking about, but hopefully it makes it clearer, is, you have a normal GFR-ish in the range of from 90 to 180. And there's basically, from the serum creatinine, no way to tell.
This is classic. Like, I was reviewing hyperbolic relationships, which is big with enzyme reactions and other things. And where we care about the normal range of GFR is the worst operating range for creatinine and kidney function. If you're working between 10 and 40, it's perfect. You're right in the operating range.
And, on here where it says highly sensitive, all of a sudden, when your GFR is 20, your serum creatinine is a real good indicator.
Exactly. But it's like the normal range is completely on the asymptote where this thing is like hit a limit.
Right.
And so it is a really interesting
so the clinical problem with this, we have on here, you can have a creatinine 1 with a GFR of 45, which is stage 3 chronic kidney disease, versus GFR of 120, which is almost hyperfiltration.
Right.
So you really couldn't tell where you were with a serum creatinine.
Yeah.
And that was a big deal in clinical medicine because people just didn't identify.
So back in the old days, before GFRs and these kind of things were clear, when you were training and in those days, as people would progress through kidney failure, you knew you were measuring creatinines. You were using just symptoms and like how were you imagining creatinine?
You would begin to have people referred to you from really perceptive people when the creatinine was 2, but more likely 3 or 4.
So as it got really advanced,
there's something that would strike a primary care provider. There's something really wrong here at that level, where we need to realize there's something really wrong when the creatinine is 1.8 or
Yeah.
so.
Or has even gone from 0.7 to
Yeah.
1.4.
Yeah. And so that ultimately is the argument for needing to know what the glomerular filtration rate is rather than the serum concentration of the filtration marker.
Yeah.
Because the serum concentration of the filtration marker just doesn't give you the right information about what's going on with the kidneys. So we mentioned the inulin clearance, and again, this is the classic original, I think, method of measuring the GFR. And what you do is you infuse inulin until you have a constant plasma rate, concentration of inulin, that your infusion rate has come into equilibrium with your filtration rate. So you're staying at a constant plasma. You do a timed urine collection, and that's what's going to give you the rate, because you measure the amount of solute that's appeared, the inulin that's appeared in the urine in a given period of time. And with a miraculous little equation that used to be on all of the medical school tests and everything, the urine concentration times the urine flow rate over the plasma concentration, you can calculate the rate that blood or plasma is made free of a given solute, in this case, inulin. And since inulin's freely filtered, it is assumed that, and not acted on by the tubule, it is assumed that the inulin clearance rate is identical to the glomerular filtration.
And that is the measured.
Yeah.
GFR.
And it's a big deal to do this test. I mean, eventually they did have radio-labeled inulin, so at least you didn't have to do chemical assays of the inulin, which were a real pain in the...
But they still mention it in the guidelines. In certain cases, to use a form of, I got to go back and find it. I wanted to do that before we got here today, but I didn't. But I will track it down and email it to you. But it's still in the guidelines that in some cases, a measured GFR is necessary.
Oh, yeah.
Yeah, not with iohexol, not with inulin.
But you're not going to measure it with inulin.
No, right, exactly.
So, all right.
Good.
So, just to mention that you can use creatinine, because we are going to use creatinine to talk about what the GFR may be in people. But you can make a guess by doing a creatinine clearance, which is doing a timed urine for creatinine and using the plasma creatinine levels. But this is a Cockroft-Gault, right? Yeah. Cockroft and Gault worked out one of the original estimating equations for the creatinine clearance, not for the GFR. They normed this to the creatinine clearance, and the creatinine clearance, depending on what your GFR is always going to be somewhat higher than your glomerular filtration rate is, because there's a portion of creatinine clearance that's secreted creatinine, not filtered creatinine. And that part of creatinine clearance becomes larger and larger and larger as your actual GFR declines. But this gave a good estimate. I used this a lot to try to figure out what was going on with people. And to this day, many pharmaceuticals have been normed to the Cockroft-Gault creatinine clearance, and it's still used in dosing some medications. And
it's one of the ones that still used age, which was an important factor from a risk standpoint.
Yeah, it's the only thing that's left.
Pretty much.
So hopefully we'll get to that. And did you see that there now is an estimated GFR equation that not only is
the European one,
no race, yes,
the EKFC,
but no sex as well.
Yeah, because they're pretty similar, and also it goes pediatrics through adults. Yeah. It's all ages. It looks pretty good. Pierre,
I don't know.
Dan.
The one I was looking at was a Swedish group that did it, and it was
This guy was from France.
It was adults that it was validated in, but they were trying to develop an equation that had no sex factor in it. So that leaves you with the measured creatinine and the age.
Yeah,
That's all.
just
And
those
I'm
two.
waiting for them to make the age go away. So,
Yeah.
all right. So this was a way of estimating the glomerular filtration rate, but it really wasn't quite close enough. The real first estimating equation, and people were anxious for this to exist given the rapidity that it caught on once it was developed, but was an estimating equation using the data from the MDRD study, a study of dietary manipulation and preservation of kidney function. And in that study, where they had, as I remember, 1,600 people, I think it was about in that group, they had lots of measured, and I can't remember whether it was iohexol or iothalamate, but they had measured GFRs and a ton of data. So it struck them that they could do regression analysis of all this data and see if they could develop an equation that would predict the likely GFR in an individual just from the serum creatinine and other factors that described the patient. And it worked pretty well. It was limited because everybody all the patients in the MDRD study, all the participants in the MDRD study had a GFR of 60 or less. So the equation really was only derived from a population of adults with a GFR of 60 or less. And so you really could only fairly apply the equation to that group of people. And to this day, if you see a report where the estimated GFR is described as greater than 60, they don't give you a number. They're using the MDRD
I
equation.
got you. Right.
So,
yeah.
So at any rate, this caught on. It did use age, sex, race, and the serum creatinine in the equation, and a couple of other things. There actually were a couple of equations, but those were the major things in the equation. So the first problem with this, it worked really well. Certainly around here, it was in the laboratory pretty quickly after it became validated. And again, given my clinical context through the ages of nephrology, it really was important because all of a sudden people were realizing there are folks out there with kidney disease that I didn't realize they had.
This came out in my first year of fellowship. Yep.
So really that long?
99.
Okay.
Yep, 99.
So at any rate, it really proved itself useful very quickly in the clinic. But the original difficulty with it was that, there they are, the 4 variables, the 6 variable with albuminuria. The real problem was that you couldn't use it in all comers. You couldn't use it in people with a closer to normal or normal kidney function.
Yeah.
So a lot of the investigators who were involved in the MDRD study developed the CKD-EPI. You know, there's so many collaborations and consortiums.
I know.
And I can't remember what kind of a group the CKD-EPI group is. I think it's a collaborative. But they decided to get a group of people from studies where the GFR was measured, but the GFR was relatively normal throughout the entire population of patients in those studies. And using that data, they were able to generate the CKD-EPI equation that we could use in basically everybody as an estimate of what their GFR was. And again, I think even moving to that GFR of greater than 60, having this equation available made people realize, wow, maybe there are things going on.
And you're identifying some trends in earlier stages, and it just was a new little view.
Yeah. And you wouldn't have identified those trends if all you were looking at was the serum creatinine.
Yeah.
And unless you were incredibly intuitive, you wouldn't have noticed that things were changing. So the CKD-EPI came into practice. An awful lot of the data, a lot of the epidemiologic data that you see now uses the CKD-EPI estimated GFR. But the issue with the CKD-EPI GFR was that it still had a race term in the equation. And it took a while, actually, but after a while, people began to realize this just isn't fair using this, because it was assigning a higher GFR to people who were identified as African American, as black.
Yeah.
And there are negative consequences to that. One, your chronic kidney disease may not be
Picked up.
identified. Two, there are things like transplantation that are made available to you
at certain levels,
given GFR, even dialysis in terms of CMS. There's an acceptable GFR to go on dialysis.
But there was some backlash. I think it even started with med students at some schools where people were learning it, and they were starting to say, this didn't seem right. There was something.
Right, and
race is not biological, so it was this thing that...
And that's the point that people make over and over again, that race simply isn't a biological factor. And I don't think I want to get into arguing this one way or the other, but it clearly became important that the race term be taken out of the estimating equations for GFR.
Because there were hypotheses about muscle mass and other stuff, but it turned out that didn't turn out to be valid. Isn't that right?
I'm not going to get into this. If you read through all the data, it's confusing.
It's confusing.
So,
but in any case, they worked towards getting a de-indexed version of the equation.
That works regardless of how you identify yourself in terms of race, ethnicity. It's a workable equation. So that was, again, the CKD-EPI collaborative review.
And there they just kind of took the two populations, right? Like the white group and the African-American group, and they reanalyzed it all pooled together.
I think that may be the case.
I think that's what they did.
When you look at the numbers are not the same. Like, as I remember, I can't read this right here. As I remember, the percentage of blacks in the original CKD-EPI study was higher than the population in the one that, is that not?
Yes, it was 31% in the CKD-EPI group, 14% in the
which
DA
strikes
index.
me as a little odd when I look at those.
Yeah,
but
that's strange.
The equation was developed, it was validated, it works, and that now is the equation that we are using, and I hope we really stick with it, because one of the things that's interesting about the eGFR is we now have all of these equations that are out there, and they're not exactly the same, and studies have been done with different estimating equations for the GFR.
And it becomes hard to compare.
And comparing things can get to be really difficult. And as we'll mention in a bit, I've already mentioned we have 2 filtration markers. And, for the most part, we have used creatinine, but the importance of cystatin C is now being recognized. And so not only do we have multiple equations, but we've got at least 2 filtration markers. And it's good that the eGFR is kind of a loose estimate because obviously these these are all different from each other.
Right.
So, and then the other thing is, I hope we can stick with this for a while. I don't know how much more shelf life I have, so I hope this is going to be, but if we have to adjust to one that takes sex out of it as well, that if there is a really strong feeling that there is a disadvantage to a population having a sex term in the equation, we're going to have to deal with things changing.
It does seem like these equations work differently in different populations, and there are these
Different
bias
age
factors,
groups,
different age
different-
groups, right? Because when I hear the Europeans talk about what they're using in this EKFC, and they compare to CKD-EPI, and they talk about their guidelines versus ours, you see, I saw one high person, and his first name is Pierre, and I can't remember his last name, but I think it was like Dan or something, from Paris, who talked about they have this equation where you can have these Q factors literally to your local population to make these equations work the best for the group of people you're looking at.
Well, I keep wondering if the eGFR isn't just going to go away. And in line with what we talked about in our grand rounds, or you're going to have population statistics and you're just going to have risk numbers.
I don't disagree with that, but I think we will still need these methods for how much of this medicine do we give you? And how do we adjust things?
There are still biological things, as we were talking about. It may be, though, that if that's really important, you're really going to use a measured GFR.
But I agree. I think from a risk standpoint, it's going to be, AI is coming.
That all of these things are merging. That's what I want to look at.
So true.
And what you're really interested in. Well, I'm going to go off on a tangent.
Good,
here.
do it. This is the place for tangents, not grand rounds.
So the original purpose for the GFR very clearly was to try to have an easily determined surrogate for the actual GFR.
Okay.
For what measured
what's really
GFR.
happening. Cheap and easy.
Yeah, that you can use in everybody to monitor people. It evolved to then being something that you could use to monitor progression in people. And progression may or may not be linked to what's actually going on with a GFR, that these equations may be predicting progression in ways that are not completely related to what the GFR is, but they work in studies. Your eGFR-X goes down, and it's a very good indicator that you are progressing. So we moved from a measurement to something to follow for progression, and then very tightly linked to following it for progression, they became risk predictors.
Right.
Which may or may not be related to the GFR, that you can show with a number of these markers, particularly cystatin C, that if you have a cohort with an essentially identical measured GFR, the cardiovascular risk varies with the cystatin C measurement in that group of people. So there's something going on that probably doesn't relate to the GFR in these solutes, these markers. So where was I? I was just trying to get to the estimated GFR now. Its purposes really have changed.
Yeah, and I think they identified, and you see this because it's like we get more granular as they move through the years of these measurements of our understanding what the buckets of these numbers mean.
I must admit, I don't understand. All of them mean something different in different populations and what they are.
True.
And so I tend to use them according to the guidelines, and I'm very interested in reading about the other associations with the various eGFRs. but I honestly, it's very hard to keep track of all of the different things that the different measurements.
It is, but even when you look
correlate
back at like in the old days, 2001, when that New England Journal came out from that study, there was Glenn Chertow's stuff where they looked at hospitalizations, mortality, and all these things, and it was like, even at high levels of GFR, as you go down the risk, these people at a population level did worse.
Do I?
Yeah, you do.
Do I have the creatinine slide in here? So this is
this is good.
This is going to be hard to understand.
That's okay. Just walk me through it.
So what this is it is the difference between the eGFR creatinine and the eGFR-Cystatin.
Mm-hmm.
And the two panels, one is just reporting it as percentage difference, and one is the absolute difference.
Okay.
So just choose one of them. If you look at this, you have a difference of minus 60. And
that's the eGFR creatinine greater than the eGFR-Cystatin as you move to the left?
Well, it's almost always that, because usually, most of the time, the eGFR creatinine is greater than the eGFR-Cystatin.
Okay. Right. Yeah. Usually.
So, in order to be seeing these kinds of things, it almost certainly you could guess it is the eGFR creatinine minus
the
eGFR-Cystatin. But basically, what you see is when you have
big discrepancies,
a big discrepancy and a high GFR, you are seeing adverse outcomes associated most likely with having a low creatinine from reasons other than a high GFR.
Right.
When you're seeing these big disparities between numbers.
Right.
And it turns out that having a low creatinine on a non-GFR basis is a very poor indicator of good health.
Right.
You're sick if you have
bad prognostic sign.
So when you look at the mortality rate graphed versus the eGFR creatinine, it comes down till about 90-ish, and then it begins to go up again. And most people feel that J-shaped curve, that upward slope, is that it's not really the GFR anymore. It's an error in estimating what the real GFR is, related to the fact that you have a low serum creatinine from reasons that have a lot of morbidity associated with it.
Got it. Yeah, that's good. But when those two numbers correlate, it's actually a very good marker of what the true GFR is.
It is. And
that's the two of them separately versus...
I think it was reading an Inker paper. Whenever you have real disparity between the two measurements, there's something non-GFR going on with one of the filtration markers.
Something's happening.
Yeah,
there are things inflammation, thyroid disease,
the cystatin C.
Right.
So you're having said this, I want to go back and show, because the recommendation is to use, if you really want to do an estimated GFR, and in most cases, not all cases, in most cases, the best estimate of the GFR is the combined creatinine and cystatin equation.
And I heard one woman talk at one of the conferences where she had said she doesn't like the combined by itself. She likes all three. She wants the eGFR creatinine, eGFR-Cystatin C, and then the combined one.
Well, just to make life difficult, what I'm working on, and we'll get soon, and you'll only have at the local hospital and not in your lab, but we're developing a GFR panel.
Oh, that's good.
You're going to get the serum creatinine, the serum cystatin C level, and then you're going to get the eGFR creatinine, eGFR cystatin, and eGFR, cystatin, creatinine.
Because seeing the three of them and some of the
Confuse
subtle
the hell out of
differences,
primary
everybody's going to be
care
completely
providers.
confused. But then it's going to bump up referrals, and we'll do some analysis here.
But
Software will figure it
that's
out.
what I think that's in the pretty near future.
Wow,
that
that's
we're
amazing.
going to have that.
So we'll have that at our local hospital here
You will have
in the
it.
lab.
I think you'll have it at CVPH.
That's great.
Doing the cystatin is a problem, so I think it's going to have to be.
Is it done in the hospital lab directly now?
Not now, but this is what I've been
It's coming.
moving to try to get it measured locally.
Yeah.
One, so that you get the results a little faster, although this will.
I ordered one, I think it was 2 months ago. I think it should be coming in the next week.
The method we're going to use, just because it's easier for the laboratory, they're only going to do it during working hours 5 days a week. So when you order it, you won't get the eGFR cystatin back
Right away.
maybe for 48 hours.
Okay.
It'll
Wow, that's
take
going to be great.
Show up in the chart. But the eGFR-Creatinine, because when you do it, they're going to do a creatinine and a cystatin C. The eGFR-Creatinine will come back
With the
as
creatinine.
quickly as
The lab comes back.
Yeah, as it usually comes back. So if you're really doing this and you're needing to have a real estimate of what's going on with the GFR, you'll have the serum creatinine and the eGFR-Creatinine. My sense is, we were talking about this and moving towards it, is you're asking, when you're doing this cystatin C, you're asking questions that you really don't need the answer right away if it's going to take a couple of days for it to come back. So.
Yep.
So that's
amazing. I'm excited for that, because most of my patients get their labs done at the local hospital, and then they feed into my system. I will have a GFR panel. That's fantastic.
Yeah, and part of this has been working. I've been working with the primary care providers to improve folks identifying people at risk for chronic kidney disease and doing the appropriate testing. That's really going to pick up at least.
And I think, as a quick aside here, I had a dinner talk with the primary care docs here. I had about 6 there, where I gave them the first 15 slides of the kidney failure risk talk. And Justin, like, if you send me a referral with a KFRE of 5%, I'm not going to question you. But if you send me someone with a creatinine of 1.6 and no albuminuria, it's coming back incomplete. You know.
So we're also going to have a CKD panel that they can order, and you just get a creatinine and a urine albumin.
Oh, that's fantastic. Oh, the albumin creatinine ratio.
Yeah, the urine
ACR.
albumin creatinine ratio.
Perfect.
So once they have that available and we've done the education, look, you really need to be doing this. These are the people who are at high risk.
Yeah.
Order this panel.
Yep.
We'll talk with you about the eGFR panel
Right.
when we need to.
That's
you don't
great.
need to worry about
No.
that. So,
Oh, that's great.
so I think we're going to have a lot more of that. And once that's going, we will get the KFRE2 and the KFRE5 calculated
That is
automatically
awesome.
and going into the flow sheet.
That is great.
So,
That was a nice little tangent. Good. But cystatin C, or I do order it occasionally, certain cases. I had one just recently, a very frail elderly woman. Her eGFR was coming back like 17, 18. She just didn't look good, and I just didn't trust it.
I mean, my experience with it is, yes, I don't trust it. And where I have not trusted it is in young anorectic people, where I get a GFR and I don't believe that.
Yeah, right.
And so I want to use a cystatin C in that.
Do you see people ordering it now, cystatin C, much in nephrology clinic?
Only nephrologists order.
But are they using it in the department there
very,
occasionally?
Very few.
So very few.
In the Navigator program, I am recommending it to nephrologists when I don't trust the eGFR creatinine.
Right.
Very hard for me to get many nephrologists to order a
to buy into that.
Yeah.
Right.
But again, we'll move towards the education, because I hope I'm not misquoting here, but my understanding of the new KD-Go is that the eGFR creatinine is just fine for surveillance, for monitoring, whatever. But when you want to risk stratify somebody in the Heatmap, you should be using the eGFR creatinine cystatin. And that will increase the number of high-risk people you have by a significant amount, particularly in some of the middle numbers, because those people are going to have lower GFRs.
Right, they're going to drop 5-7 mLs per minute.
And so that's what I'm trying to move towards and educating people about what you should do. I've tried to find out whether you can substitute different eGFRs in the risk equations, and I haven't been able to come up with an answer for that, but I did see an Navdeep Tangri talk where he did say, well, it's an interesting idea, but it hasn't been validated in these great big populations.
The EKFC people, one lecture I watched, did bring that up. And that was one of the questions at the very end. Hey, can we use this GFR EKFC in the risk equations, and how do you see that happening?
And what was the answer?
The answer was no.
Yeah, and I think, if you haven't validated in a population of 2 or 3 million people, he won't say to do it.
But then that also brings up this point of, okay, now we're managing people using this new version, but our interventions are based on these other buckets. So the buckets have changed a little bit.
And that's what I was saying at the beginning.
Right.
It's really
confusing
with all of these different things. And my hope is for a very mobile world where you have consistently evolving risk equations, and as large databases are
AI is going to help us sort this out.
Yeah, that you're going to have continuously evolving assessments of risk that will be based on what you have available to you in the population that you have.
Yep.
So
excellent.
Let's
go back some slides.
I don't know what else I have to say in here. I think we've covered almost everything.
That's a good one. I like this. This
is because it really makes the point that the estimated GFR is a guess at the estimate. I mean, it's miraculous to me that it works at all.
Right.
That you can take somebody's age, sex, at one point in time with a serum creatinine, and from a population of a couple of thousand people,
come up with
end up with a regression equation that gets you anywhere near what the measured GFR.
But you can also see between the MDRD and the CKD-EPI that median line there, it's a little higher. The bias is off a little bit on the MDRD, skewed upwards, and the CKD-EPI is closer to the 0 mark.
Clearly, you want to be at the 0 level for your overall average to be approximating what the measured GFR is. And the MDRD, when you looked at higher numbers, it really overestimated the GFR. Here you can see also that even the CKD-EPI is, on average, overestimating the measured GFR. And that is the issue that... what did I do?
Oh, just click the mouse again because there's a little window up. Oops.
Where was it on?
There it is. It was on a little...
Okay.
Yeah, there you go. Almost.
Click it there. There we go.
You got it.
There. No.
Yeah. The arrow should work now.
It is not working.
Let me see. Okay. Try the arrow now. There you go.
Whoop. This is what I want. This is a relatively small population. This is a single population. I think it was about 1,500 people that had a cystatin C, a creatinine, and a measured GFR done. And just to show you that this is the group of people where there's a negative difference between the eGFR cystatin, eGFR creatinine. So these are the eGFR cystatins. They're higher than what the measured GFR was. These are the eGFR creatinines, I believe.
Yeah, the green.
that are lower. And when you look at that population, if you look at the combined eGFR, cystatin, creatinine, you while there is a bias to it at higher GFRs, you come pretty close to the line of identity with a measured GFR. So if you have...
It does a better job.
It does a better job than either one of the estimated GFRs alone. This is the opposite. This is the eGFR creatinine is overestimating the measured GFR. This is the eGFR cystatin C is underestimating what the measured GFR is. And this is really the largest population that you have when you look at these things. But again, if you look at the combined filtration markers, although there is a bias as the measured GFR goes up, you are pretty close to the line of identity, especially in the range of GFRs that you're interested in, most people. And if all three of them are close, they're close.
Right, then you're good to go. They kind of correct each other.
But this, to me, was the best visual argument. There are a lot of big tables that demonstrate this from hundreds of thousands of
but
people.
This is the easiest picture to understand.
Yeah.
Yeah. No, I definitely see that. And there's such a difference with these as you get older because creatinine and age is a different relationship.
Yeah.
And GFR with age is a different relationship.
Yep.
But and so is cystatin C with age. I mean, cystatin C goes up as you get older.
Risk equations rather than eGFR.
You got it. I mean, it's what, yes, right.
So
that's interesting. That's good.
All right. I don't know
that
what
was a
else to
great
talk
review.
about.
No, I think that was fantastic. That was just what we wanted. Let's see. Was there anything else big in there?
Looking at a population, again, about, I think this was about 1,800 people, where they did the eGFR cystatin, not the combined, but the eGFR cystatin and the eGFR creatinine, and they looked at what would happen to your classification in the Heatmap. And so if you used the eGFR cystatin compared with the eGFR creatinine, about 66% of patients would stay in the same cell on the Heatmap. About 7% would look as though they're lower risk, but about 27% of the patients would move to a higher risk cell if you were using that different eGFR, if you were using the eGFR cystatin.
Yep. So. No, that's excellent. I guess one of the things for for people is if we have this GFR panel, that's going to answer the question, because then you have this eGFR cystatin or the combined, which is essentially the best.
Well, somebody's going to have to decide to order it.
But in general, when that person walks into your office and you're trying to figure out, they have a creatinine of 1.6, 1.8, and it's what do I do with this? Do I order eGFR? I have an eGFR creatinine in front of me.
Yeah.
They come in, they're 5'4", 360 pounds.
If somebody's been referred to you, if somebody's going to be referred to any of our nephrology providers, I'm going to be pushing
eGFR
at least
cystatin.
once the first time you see them, do the eGFR panel so you just have those numbers.
Yeah.
So.
Yeah. No, that's excellent. Yep. Perfect. Jeff, thank you so much for coming over Lake Champlain, coming by ferry boat and driving here.
It's a gorgeous day.
It's a gorgeous day, and I loved having you here. And we'll do it again. We'll pick another good topic, and that was really fun. So take care. Have a good one.
All right.
All right.
It's almost done.
Yeah, it's perfect.